So welcome again, everybody, to the first of the Spring Faculty Forum at UW Eau Claire. It is really my great honor and pleasure to introduce the first speaker of the series for the semester. Here we have Dr. Nishant Saran, who holds a Bachelor of Medicine and Bachelor of Surgery degree. He currently works at the Department of Cardiovascular Surgery Department at the Mayo Clinic at the Eau Claire site. So thank you, Dr. Saran, and the forum is all yours. Just as a reminder, folks, during the presentation, if you can mute your microphone, and questions are obviously welcome. You can use the chat function, or at the end of the presentation, you can unmute yourself and ask the question. Thank you.
Hello, everyone. Thank you for giving me this opportunity to present some of my research at this prestigious forum. I am a heart surgeon and I work in Mayo Clinic. My focus areas include coronary artery surgery, minimally invasive heart surgery, aortic surgery, and device development. I'm just using one of my focus areas as the topics for today, that is coronary artery bypass grafting, current trends, and conduit selection. So I have no disclosures. The heart is supplied by coronary arteries. There's one on the right and two on the left, which primarily supply the three regions of the heart. The front region is supplied by the front artery, which is called as LAD, and the lateral wall, or the left side lateral wall, is supplied by left circumflex. While the right and the inferior aspect of the heart is supplied by right side of the right coronary artery. What we deal in coronary artery bypass grafting is we are dealing with blocked coronary arteries that have series of atheroma deposition that progressively occlude the coronary artery, and at times may happen that these plaques may disrupt and totally occlude, leading to what we call as heart attacks. Our goal, therefore, is to provide or restore blood flow to the heart. And what we do in coronary bypass grafting is we sew a graft distal to the blockage in order to supply fresh blood or to provide a new blood supply. That's what we do in coronary artery bypass grafting. Now, coronary revascularization therefore has several challenges. I mean, what are we looking in an ideal operation that we want to do? We want great survival, and we want great early results, lower early mortality. We want lower need for any future interventions, future surgeries, or stenting. We want an improved quality of life minus any symptoms. And we, of course, after surgery do not, or any intervention, do not want any of the risks that go with it, like stroke, bleeding, heart attack, or any rhythm issues. And then last but not least is we want to make sure that we don't create a big incision. We can approach in a minimally invasive fashion without causing a big scar or just through a small poke. So what are our options? Yeah, the options include PCI, which is an acronym for percutaneous coronary intervention. In popular lingo, we call them stenting. And the other is coronary artery bypass grafting, which is what a heart surgeon would deal with in terms of coronary revascularization. Within coronary artery bypass grafting, there are two options, which can be beating heart, which we call as off pump. And one is where we require a heart and lung machine to connect to the body. It's called as on pump. And then the most crucial part of any CABG surgery, as we call coronary artery bypass grafting, is what conduits do we use to bypass these blockages? Should we just use an arterial conduit like any artery in the body, or should we use a piece of vein from the leg? So what here stands for left is L is left internal mammary artery. It's an artery which runs inside the chest wall. SV stands for saphenous vein, which is a vein that runs in the legs. and RA here is radial artery, which is an artery in our arm. These are the few conduits which we can use for bypass grafting. So I briefly talked about PCI versus CABG. This is what we do in a stent. What we do is we make a small poke in the groin or in the wrist, and we pass a wire up through the vascular system and across the coronary artery and across the blockage, and then deploy a stent, reopening the blocked coronary artery. In bypass grafting, what we do is the blockages remain where they are, but we just essentially bypass those blockages and provide new blood supply from alternate sources. Now, the results of PCI versus CABG has been well documented. There have been multiple randomized trials. The most recent, I've just enumerated 5 randomized trials here, which have looked at these two modalities and compared them. And it has been found that each modality provides good results in some group of patients. One is not a good fit for all. So for example, in multivessel disease, wherein all the coronary arteries are blocked, or there is a significant blockage in one of the most important coronary artery, is the left main, we find that CABG is superior. In terms of overall death, there are fewer deaths with CABGs, heart attacks, lesser incidence of stroke, need for future any interventions, and similar results were obtained with other trials too. So for us, that essentially means that for a simpler disease, whether you have a single vessel blockage or you have a discrete lesion, then yes, a stent would work and provide great results. But where there is a complex anatomy, where a stent may not work, it involves multiple stents, then yes, we should look at options which include surgical revascularization, and that would be coronary artery bypass grafting. In terms of when and how this started and what are the current trends, CABG is we started doing it more often since 1962. The first time it was done, it was actually 1950s. PCI actually originated in 1977. CABG has been there for around 50 years. PCI around 20, 15, 20, more than 20 years, 30 years, to be honest. Evidence for efficacy in multivessel disease and left main disease, the strong efficacy in terms of CABG, but slightly weak on PCI. Both these approaches have benefited from improved medical therapy in terms of use of aspirin, certain lipid lowering agents, cholesterol lowering agents, and some blood pressure medications which allow remodeling of the heart. And there are some technical advances in both these approaches which have improved their success. For example, in CABGs, now there's an increased debate about using arterial conduits and use of off-pump CABG. And in the PCI group, it is use of the drug-eluting stents, which these are basically stents which are coated with drug to increase the patency and the longevity of those stents. In terms of CABG, what we look at, therefore, is what are the options? The more recent is the off-pump. What we do there is we essentially stabilize a portion of the myocardium with a stabilizer, open the coronary artery, put in a shunt across it to allow the blood flow to continue, and then bypass this after sewing the graft to it. Now, for us, the most important part, for my focus is what conduits should we use in coronary artery bypass grafting that would allow get better results, longer survival, reduced risk of repeat intervention. So some of the conduits, as I earlier discussed, were the vein grafts. These are the blue vein grafts which you harvest from the leg. Then these are grafts which are internal mammary artery, which run inside the chest wall. The fat here is in yellow. It's a pedicle takedown in the form of a pedicle. And this one here is the same IMA, but the harvesting technique is different, where we have skeletonized the IMA. And here we have used a piece of radial artery from the arm. So these are different ways you can bypass and use different configurations. You can do lima to the one of the arteries, LAD here, which we prefer, and vein to others. Then we can use both the IMAs, the left and the right, to bypass. And then we use a radial artery here. So it's like total arterial. And then there is a composite grafting where I use the lima to go to the artery here, and then use piece of rema, sew it to the lima and bring it out. So a lot of things go into speculation here. Now the speculation starts that which conduits are better than what. There's one thing that has been firmly established, and there's no doubt about it, and that came as far as back as 1986, when we found that when we use saphenous vein grafts, the survival at 10 years is around 71%. However, when we use the left internal mammary artery as one of the conduits, the survival improves by around 12%. So at 10 years, you have more, we are saving more lives. Absolutely stunning mission here, when a discovery, when this came forward. So this established the supremacy of left internal mammary artery, and we have been using that since then. This led to guidelines being published, which said that the left internal mammary artery, or lima, should be used to bypass the LAD whenever indicated. It was all class 1 recommendations. The American Heart Association also came up with possible suggestion that if the left internal mammary artery is damaged, then you can potentially use the right one too. Now, once it was established that left internal mammary artery is superior, other investigators thought, what if we add the right internal mammary artery to the usage too, and see what are the results then? This was published by Bruce Little from Cleveland Clinic, and they found that the survival was again improved when we used both the internal mammary arteries instead of just one. And there was a reduced risk of any future operation again when we used both internal mammary arteries compared to just a single internal mammary artery. So this was big. Another study was published in Lancet in 2001, which established that when you use BEMA, your survival improves. It was a meta-analysis with multiple studies being included, and they found that the hazard ratio essentially was very much in favor of bilateral internal mammary artery use. So this, therefore, led to another guidelines being published. These guidelines said, okay, now you can use bilateral internal mammary arteries to some extent, but the level of evidence is not huge, so we'll just give it class 2A recommendation, meaning it is reasonable to use, but it's not that it should be mandatorily used. Then there were some issues that were addressed here, saying, okay, if a patient does not have any excessive risk or risk of sternal infections, then you can use a bilateral. Or if the patient has a expected life, has a life expectancy within an excess of 30 years, then maybe, yes, you can use BMAs. But again, all of these evidences were poor here, level of evidence B, so it was just that. Then the other thought was like, okay, if vein graft is not good enough, why should we use some other conduit like a radial artery? And this was published from Mayo Clinic 8 years ago, and we looked at use of all arterial conduits versus left internal mammary artery and the saphenous vein. And again, we found a 10% difference in survival at 15 years. People who had arterial conduits had improved survival. So we looked at, in terms of freedom from any future events, in terms of death, in terms of stroke, in terms of events like need for revascularization or repeat operation. And we found that when we used a radial artery, that's the artery that supplies the arm, we actually have much better results. 95% of the patients are free from any of these events almost 30 months post-op. So that was our follow-up for these radial artery conduits. So this then led to the guidelines again being published, which said, okay, total arterial revascularization, yes, maybe. But again, It's even a lower recommendation level, class 2B, class 2B, class 2A. The only time when it was said, okay, you can do it is when the vein quality is poor. So there's still some debate. There's not good enough studies. There, after this, then came the suggestion that when should we use the additional mammary artery, if it should be used. And the accepted belief was, if there is a left coronary artery target, you should use the lima. But if you have any other vessel that should be used, and if you can't use lima, then use the rima. That's the right internal mammary artery. You should use it if there's a definite degree of stenosis, like if the arteries of the coronary artery is blocked more than 70%. And if these risk factors are not present, if the patient is not too old, the heart functions are good, patient is not obese, does not have too many comorbidities in terms of diabetes or a lung disease, then yes, you can use an arterial conduit like a right internal mammary artery. And then there was a question of how much time does it take? Does it increase the length of the operation to harvest another internal mammary artery? A lot of surgeons were actually worried about this. So time was another important factor. There's enough evidence to say that longer the operation continues means the operation is more complex and the results may not be as great. So there was one randomized trial to answer all these questions that came published in 2016 in NEJM. And it looked at bilateral, the two internal mammary arteries versus just the one internal mammary artery. What they found was at 5 years, there was no difference. So all the evidences that we had before essentially was put in jeopardy with was put in doubt essentially when we said, okay, at 5 years, it seems both these things are not different. So why do we do that? Now, that's where we decided to look into it ourselves from Mayo Clinic. And we said, okay, what we can do is we have a huge pool of patients. We will go back and look at our own patients and see how we have done. We looked at almost 9,000 patients from 2000 to 2015. We included all those patients who had multivessel CABG and excluded patients who had just one bypass graft, or if just one IMA was used, or any other concomitant heart surgery was done. So essentially, we included only patients who had isolated multivessel coronary artery bypass graftings, and we included around 6,500 patients. That's a huge number. Of them, around 1,000 patients received the bilateral IMA, and around 5,000 patients, 5,500 patients used the single left IMA. Now, there's a definite bias there. I mean, the bias does not exclude our surgical community here. So it might have been possible that these bilateral IMA patients would have been lower risk, would have had lower risk profile. So what we did in terms of our analysis was we matched these two groups to identify patients with similar risk profiles. And then what we wanted to look at was what was the difference in survival and whether any of these high-risk factors like ejection fraction or lower heart function, higher BMI, low, increased age, lung disease, or stroke, or diabetes has any impact on the usage of bilateral internal mammary arteries. In our own experience, we have used around, since 2000, around 10 or 12% of our CABGs have used bilateral internal mammary arteries. Since 2012, when we published our multi-arterial paper, the usage of bilateral internal mammary arteries has increased to around 30% as far as 2015. Now, if you look at this slide here, you would find that the left internal mammary artery patient, these are the risk profiles of both the groups. And you would see that the left internal mammary artery group were older people, while the bilateral internal mammary artery were younger. Females were more common in the single internal mammary artery group and less common in the bilateral. In terms of comorbidities, again, the bilateral internal mammary artery group had half the comorbidities, what compared to the single internal mammary arteries. Similarly with body mass index 2 and in heart failure, only 1/3 of the patients were in heart failure with BMAS compared to in congestive heart failure. And if you look at stroke 2, it was similar. So in all, if you look at these two groups, you can say, hey, the bilateral internal mammary artery group have a lower risk profile. So how can we compare these two groups? We cannot, these are apples and oranges. We cannot compare. So what we did, therefore, is we matched the internal mammary artery, bilateral internal mammary artery group to similar patients in the left internal mammary artery group alone. And we found a group of patients that similar risk profiles. And the standardized differences between these two essentially disappeared. It went down to 0.00, 0.0 everywhere. So meaning that these two groups were equally well matched. And if you look at this graph here, distribution of the propensity score, you would appreciate what I'm trying to say, that after matching, both these two group of patients had similar risk profiles. So essentially it became it's the best evidence we have outside a randomized or meta-analysis in terms of matching these two groups according to the risk profile. And then we looked at the outcomes. We found that the vein grafts were, of course, less often used in the bilateral internal mammary artery. Radial artery were more often used in the lima alone group compared to the bilateral internal mammary artery group. And interestingly, the use of heart and lung machine and in terms of perfusion time, how long did we use the heart and lung machine, was somewhat lower in the bilateral internal mammary artery group. Other than that, the results were comparable, but yes, the cross-clamp time was higher in bilateral internal mammary artery group, which was expected. The incision time, how much time the patient was in the OR, was of course longer in the bilateral internal mammary artery group because it took longer time to harvest the conduits. And then we look at the results, we found that essentially there was no difference between these two groups in terms of immediate postoperative outcomes. Length of stay was similar, readmission within 30 days was similar, but the length of stay in the ICU was somewhat lower in the bilateral internal mammary artery group. One of the concerning features was the infection. When we operate, we go through the chest, the incision on the chest, whether there's any infection after the surgery. And we found that the risk in bilateral internal mammary artery group was almost twice. The incidence was twice higher in the bilateral internal mammary artery group compared to the left. And this is somewhat understandable because the internal mammary arteries supply the breastbone of the chest and is important in terms of providing blood supply for the healing of the bone. So an increased risk for infection is understandable. However, when we looked at the deeper infection, was there any deeper infection? Yes, there may be some superficial infection in terms of skin, but what was the bone healing involved? And there was no difference statistically. There was no difference at all, 0.088. Yes, there were some increased numbers, but the numbers are too low, 5 versus 12. So it's hard to actually argue there in terms of what is better in terms of bone healing. But the absolute difference was identified in terms of long-term survival. Fewer patients died in the BEMA group compared to the single IMA group. And this difference can be seen in this graph. Around 4 years, this graph starts to separate, and it becomes wider around 10 years when it starts getting separate. So the BEMA, the blue line, gets farther away from the red line, which is the lima alone, meaning that patients with bilateral internal mammary arteries end up living longer and much further as compared to the lima alone. Then we looked at those high risk factors and we're wondering, okay, whether those high risk factors like age, gender, low heart function had any impact on the survival. Did they influence the the longevity that is provided by BMAs, and there was no difference. I mean, none of these high-risk groups had any effect on the survival advantage that BMA provided, essentially meaning that bilateral internal mammary arteries can be used in all these groups and will provide equal survival benefit as it would in any other patient. So, for example, patient who's younger will have the same survival benefit as a patient who is older. Same with low EF and presence of comorbidities or not, like diabetes, stroke, cerebrovascular accident, lung disease, even when the surgery was performed in an urgent or emergent fashion. So this was important to find that even high-risk factors do not preclude the use for bilateral internal mammary arteries, and therefore we should be using them more often. We wanted to look at the sternal site infection because that was one thing we found with bilateral internal mammary arteries. So we looked at all those high-risk factors which could contribute to these infections, like gender, diabetes, high BMI, presence of chronic lung disease, and the year of surgery. And we found that, yes, overall sternal site infection were higher in the BMA group, but that included both superficial and deep. Now, if we look at just deep, that meaning involving the bone and bone healing, we found there was no difference at all. So that was again encouraging and in favor of bilateral internal mammary arteries. A superficial sternal site dehiscence can still be taken care of, and it's not debilitating. It's we need to be just aware and manage it post-op, and it can be done without any quality of life issues. So we concluded, therefore, that our second IMA is a superior conduit to other available conduits, irrespective of target and degree of stenosis. We also concluded favorable outcomes can be achieved even within the high-risk patient subgroups, and a BMA should therefore be treated as a gold standard. And therefore, there should also be a more extensive use of BMA in heart surgery. This was the paper we published on this, which was published in 2018 in Journal of Thoracic and Cardiovascular Surgery, which depicted this research. Again, thank you for the opportunity to talk about my research and focus on conduit selection in coronary artery bypass grafting. It has been a very exciting partnership with the University of Wisconsin, and I'm looking forward to any questions that we may have.
Great. Thank you so much for the, very exciting and very, to me, it opened a whole new, I guess, chapter of exploration for me. I guess does anybody have immediate questions? Because I don't see anything in the chat room. But you can unmute yourself and ask your questions now. And while folks may be thinking of the question, maybe as a layperson, a non-medical, non-surgery person, I can ask. To me, it is really intriguing, I would say, to find out that there are, to me, a vessel is a vessel, a conduit is a conduit. But I'm actually really surprised to see that the choice of the conduit actually seemingly has a profound and significant effect, at least, on the outcome of the patient. So is there any explanation for that? How does one actually go about choosing the conduit if there are multiple, multiple possibilities available to the surgeon?
Absolutely, that's right. That's the right question to ask, and also that question has been asked so many times. I mean, like it's an ongoing debate, and we're still trying to answer those questions. What conduit do we use? Now, there's no doubt about one thing, that if you use an arterial conduit, especially the left internal mammary artery, which runs inside the chest wall, it's a better conduit than the vein graft. Now, vein graft, a vein is not designed, your body to have or tolerate an arterial blood flow. An arterial blood flow needs a there's a higher blood pressure requirement. The way an artery is designed, and there's an adventitia, there's a media, and there's an intima. So there are coverings of the arterial wall which are designed to withstand that pressure. A vein graft, on the other hand, is not designed to withstand that higher pressure. So when you use a vein graft, the logically, intuitively, it may not work, because when you're putting it in the heart, you're actually providing an arterial blood flow into a vein graft. So the vein graft can potentially go down because it's not designed. And that's what we see in terms of evidence. However, when we have looked at our results and we've compared, okay, can we use vein graft everywhere in the heart? And we found that no. When you use an arterial conduit to the LAD, which is the primary vessel and supplies the pumping chamber of the heart, there's no doubt that the left internal mammary artery is far superior, and the vein graft is not going to last. The debate therefore starts is whether the other targets, other coronary arteries, can we use arterial conduits there, or should we continue with vein grafts? And we now know with some evidence that using an arterial conduit is a better example, because it will provide longer patency. The flip side is a lot of these patients don't live long enough to provide us the credible answer. Okay, a vein graft would fail at 8 years, 10 years. Some vein grafts have stayed open for 15 years. But yes, they start failing at 8 years, 10 years. So if they don't live long enough, then we are in a problem. That how do you find that difference? So that's where when age comes as an important factor. Should we do it in younger patients, younger population, and use that? So a lot of our research therefore goes into looking at events like, okay, forget about survival, let's look at events, whether the patient had another heart attack, needed another procedure, was he chest pain free? And when we look at that, there's enough evidence accumulating that vein grafts may not be as good as the arterial conduits. The next problem is, how many arterial conduits do we have? And that supply is limited compared to the vein. There's a long vein that runs in the leg and we can use it. So a lot of times we have that limitation. To overcome that limitation, we have designed the use of the right internal mammary artery in terms of different configurations. And there's research going on, and I'm working on that research right now, when I'm looking at a particular configuration I can use with just the 2 internal mammary arteries and be able to supply all my coronary artery targets and not use any vein at all, and see how those results are. The preliminary results are pretty good. Actually, they are very exciting and they show much better survival. So we were to present this in our annual meeting with Western Thoracic Surgical Association, but because of COVID, the meeting got canceled. So yes, to answer your question, short, the difference is vein is not designed to have those higher flows. And then the left internal mammary artery is something which is called as nitric oxide. The cells within it secrete nitric oxide, which keep it patent and keep it vasodilated. Unlike radial artery does not secrete nitric oxide and can undergo spasm. So these are different characteristics to each conduit. I did not include it in my discussion because for the time purpose, I wanted everyone to just make sure that everyone understands that. Okay.
Great, thank you. It's really starting to make sense to me now. So thank you for the answer.
Absolutely.
As a follow-up, I mean, does the surgery department ever track the quality of life as an outcome? I mean, apart from having other emergencies or death events, is quality of life taken into account as the patient recovers from surgery?
Yes, yes, it is. And there have been some papers published just looking at quality of life. And quality of life indices can include several things, like improvement in heart function can lead to improvement in quality of life. Freedom from chest pain can lead to improvement of quality of life. Um, Return of ability to exercise, walk, do your regular things. And there's no doubt that quality of life improves with coronary artery bypass grafting. No doubt about that. And question is whether there's an improvement versus vein graft versus arterial conduits. And there is evidence now accumulating that arterial conduits allow an earlier return to a better quality of life. And freedom from chest pain, freedom from future events needing a stent or heart attack, again, is lower. So yes, you're right. Quality of life is tracked by us, and we look at that as one of our parameters.
Great, thank you. Any questions from the other attendees or participants? Don't be shy. So, Dr. Saran, did you mention that you have a collaboration with campus UW-Eau Claire?
Yes, there are a couple of projects that we are doing with Eau Claire, UW. And we are specifically looking at our coronary artery bypass grafting results in, in Mayo Clinic Health System in Eau Claire. And we are collaborating with UW Eau Claire to see and analyze those results and see where we stand. We're also looking at another project where we're trying to look at minimally invasive heart surgery in terms of valve replacement and see how they have improved the quality of life in some fashion. Like our measure for quality of life is their 6-minute walks test and earlier return to work. And we are doing that. Dr. Calvin is the PI and the co-PI on that, and we are working together with the University of Wisconsin Eau Claire on that.
Great, this is exciting. So hopefully we can get you and or Dr. Calvin to come here and share your work again in a future date.
Absolutely, absolutely.
I don't want to hog the forum time. Does anybody have questions? Since we're nearing the, I guess, the end point for the event today. Well, thank you for your time, Dr. Saran, and then thank you for sharing your expertise with us. So hopefully we will be able to see you and or your colleagues at the forum at a future date. And hopefully by then we will actually be sitting around a table or in a room in person as opposed to using a virtual format.
Absolutely. It was a pleasure. Thank you so much, Catherine. I appreciate this opportunity.
Yep.
Bye-bye.
Thank you. Thank you, everybody.
Thank you.